Hello everyone, and welcome to this point-of-care ultrasound case-based discussion. Today we're covering the abdominal aorta, primarily targeted at the third-year family medicine clerkship. So let's jump right into the discussion. I am going to include a hyperlink here. Reasons to scan the abdominal aorta. There's basically two indications, and that includes patients who are symptomatic. Symptoms of an abdominal aortic aneurysm may include back or flank pain, may also include abdominal pain. They may just present with undifferentiated shock, or they may have, embolic signs in their lower extremities. So those are all reasons to think about a symptomatic abdominal aortic aneurysm. The other one that we really want to target specifically today in the primary care setting would be in patients who qualify or should undergo screening for an abdominal aortic aneurysm, and we'll talk about those guidelines. Really quick review, bedside or point-of-care ultrasound of the aorta. The big question is there abdominal aortic aneurysm, yes or no? That's really all we're trying to answer. And for rough remembering, you can remember 3 centimeters is really probably 2.5, but 3 is a nice round number that's easy to remember, so keep that one in mind. Just reviewing the anatomy, again, the abdominal aorta sits in the middle of the abdomen. We want to obtain transverse views in the subxiphoid region, and then we just want to follow it all the way down until we see that bifurcation into the common iliacs. And quick reminder that 95% of abdominal aortic aneurysms are infrarenal. That's a good quick board review little topic to keep in mind. Real quick reminder of the anatomy. So here we've got a transverse view, and this is kind of close to the epigastrium, it looks like, because we see part of the left lobe of the liver. Always identify that vertebral body first. That's kind of your first important landmark. So look for that bright arc with a shadow behind it, and then look for the round pulsatile thicker walled aorta sitting on top. Then you'll often, not always, it may be compressed, but you may see the more almond-shaped, thinner walled, more phasic inferior vena cava to the patient's right as well. So those are the primary anatomic landmarks. Again, review that hyperlink earlier for a little more detailed review of the anatomy. When we measure the abdominal aorta, we want to measure the outer wall to the outer wall, and in contrast to what's shown here, the most accurate measurements are usually the anterior posterior, so from here all the way to here. So we don't measure inside any thrombus, we don't measure inside a false lumen. We want to measure the entire aorta from the outer edge of the wall to the outer edge of the wall, and that's where you get your accurate measurement. The anterior, so from here to here, is the most accurate measurement. You may also include lateral measurements as well, but sometimes because of the way the sound waves hit those walls, they're not as well defined and as clear on ultrasound. We'll briefly mention and we'll show some examples of aortic dissection, because if you have a symptomatic patient and you identify this, you certainly want to know that as soon as possible. Ultrasound has a very high specificity to help diagnose aortic dissection. However, it has a lower sensitivity, so you can't exclude aortic dissection with ultrasound. If you have a patient where you suspect aortic dissection and you do not see it with ultrasound, then you probably need further workup. Just point that out there. A few pearls, again, we're mainly looking for enlarged aorta. We cannot exclude or clearly accurately identify whether there's a leak or a rupture in the dissection. It's there, yes or no, and then there's symptoms and the rest of the picture. And maybe other workup might be necessary to help you decide if there's a leak or a rupture. Like a lot of things, the patients don't present with classic symptoms, so less than half of ruptured AAA patients have classic symptoms. Remember that number, 3 centimeters is your rough number to remember for an aneurysm. Anybody, even in screening or asymptomatic patients, if you identify an aneurysm greater than 5 centimeters, that should be referred to vascular surgery for repair, or aneurysms that enlarge significantly from year to year. If you're following one more than 2 to 4 to 5 millimeters per year, those are higher risk, so those certainly need referral as well. Pretty intuitive that the larger it is, the more the risk of rupture. And just to point out, the reason we screen is patients who have asymptomatic aneurysms and who are able to undergo elective repair. They have a much lower mortality compared to once they actually get symptomatic. Once they get symptomatic, their mortality is quite high, which you can reduce by identifying it early and not missing the diagnosis and getting them to surgery soon. But if we can find it before it's symptomatic, that's where we can have the biggest impact on mortality. And like we mentioned before, most of these are infrarenal. So our first case is a 78-year-old patient who presents with back pain on the left side, has some nausea, no trauma, has a history of hypertension, and is a smoker. You can see this patient's quite hypertensive at this point, otherwise their vital signs are pretty unremarkable. Patient appears to be in pain, kind of has some diffuse abdominal tenderness, but no spinal tenderness. So again, this is a patient that's over the age of 50 with back pain. We should always be thinking about their aorta in these kind of cases. Ruptured AAA, but dissection is also on that list. So in this case, we get some bedside ultrasound pictures, and you'll see sometimes the pictures aren't beautiful. That's real life and how that happens. But we can still recognize here is that shadow from the vertebral body, and sitting on top here is the abdominal aorta. Now, even though this isn't the clearest, best picture on earth, we can answer the question, is it too big or not? In this case, this is not an enlarged aorta, so that answers that question. Obviously, we're going to follow the entire length of it. Here, we've gone down a little further. Again, we look for that landmark of the vertebral body, and then here we see we've already split into the common iliacs, and they look okay. They do not look enlarged. So this patient does not have a AAA, so we can move on to the other things on our differential diagnosis for this patient. I think it's important to point out here that if this patient who presents with symptoms that are concerning for an abdominal aortic aneurysm, let's just say hypothetically it was positive, if we saw signs of an aneurysm, and we'll look at some examples of what that looks like earlier. How does that help you, and how does that help this patient? Well, depending on where you are, that may be enough information that you decide you need to transfer that patient. Maybe you don't have the capability to care for that patient in your local facility. Say you're working in a small emergency department or a small clinic, you're going to get that patient out of there. If you're in an emergency department, say you're in a big referral center like we have here in Morgantown, and you see that this patient has an aneurysm and they've got back pain, you're concerned that this is a symptomatic abdominal aortic aneurysm, that information helps guide you into what to do next. You may start mobilizing resources, involve vascular surgery early on in the care of this patient. Ultrasound is not going to replace a CT scan. If the patient's stable enough to go to CT, then you're probably going to go to CT scan. But now with this information you have, that patient moves up the priority list. They go first to CT scan. You make sure that they have 2 IVs. Maybe if they're getting symptoms, if their blood pressure's soft, you go ahead and make sure you have blood at the ready and on standby. If the patient's unstable, you may involve vascular surgery, and that sometimes may be an indication. Unstable with a symptomatic abdominal aortic aneurysm, they may go straight to the operating room without getting a CT scan. So those are the ways that this helps you in a patient. Say, hypothetically, if you find findings of an abdominal aortic aneurysm in a patient that has symptoms that are consistent with rupture. I think that's important to point out and understand how this can affect and improve your decision making. The next case is just a patient who was brought in with no symptoms, but for screening. Wife is concerned about the patient's blood pressure. This is a 65-year-old man, is a smoker, but with no complaints. And so the most up-to-date guidelines I have at my fingertips, but always check what you have in front of you. These do get updated periodically. Any man between the age of 65 to 75 with any kind of smoking history. There are some other guidelines from other task forces and other recommendations that include women, include people with family history. So again, take a look at what you're using in your practice. And so this patient, again, who's asymptomatic, but we look and we find pretty readily large. We don't even need to measure to recognize this as abnormal. We see the vertebral body. We see this large aorta. We measure from outer wall to outer wall, and we see that it's 6 centimeters. It contains some thrombus as well. So this patient definitely needs referral to vascular surgery to consider an elective repair. Just some more examples so you can see what they look like. Again, when these are there, they're relatively straightforward and obvious to see. So here we see the vertebral body, aorta sitting on top, and it's obviously enlarged. Don't need to measure it to recognize its presence, but then we want to measure from outer wall to see exactly how big that is. That one, just eyeballing it, looks like it's probably 7 centimeters or so. In this example, again, we see the vertebral body here, shadow, and on top of that, we see this pulsatile aorta with lots of thrombus within it, but we measure outer wall to diagnose this abdominal aortic aneurysm. And if you see thrombus within it, then that's an aneurysm, whether the measurements even perfectly add up or not. A couple more examples. Again, look for the vertebral body as your important landmark. Here, we're close to the epigastrium. We see the left lobe of the liver. And in this case, we see the abdominal aorta with a mobile flap within it. So this is a case of an aortic dissection. And again, we can't exclude this with ultrasound, but we may rule it in quickly and help us guide the next steps in that patient's management more efficiently to help hopefully save their life, because again, once these become symptomatic, the mortality is quite high. On this case, vertebral body here, nice shadow. And again, we see the abdominal aorta and we see a mobile pulsatile flap within it. This is another case of aortic dissection. Remember, you cannot exclude aortic dissection with ultrasound, but you may rule it in more efficiently. So just in summary, this is a relatively straightforward and easy exam to do. It's non-invasive, but it has life-saving benefits, so worth including in patient care. The limitations, as we kind of beat to death at this point, You cannot exclude dissection, although you may rule it in, and you can't accurately detect rupture or leak, just the presence or absence of an abdominal aortic aneurysm. I hope that was helpful, and thanks for tuning in, and we will see you in the next one.